Recorded.
And I will be talking today about sleep and fatigue education in residency. So full disclosure, I did not make this presentation fully. This was by the American Academy of Sleep Medicine, but I've edited it a little bit so that kind of to pare down the content a little bit and try to put some more interesting facts in there, but it sort of is what it is, and it's a GME requirement, so we'll get through it together. All right, so I have no disclosures. So our objectives today are to list factors that put you at risk for sleepiness and fatigue during your training. We're going to describe the impact of sleep loss on residents' personal and professional lives and on resident and patient safety. We'll learn how to recognize some signs of sleepiness and fatigue in yourself and others, challenge some common misconceptions among physicians about sleep and sleep loss, and learn some strategies to adapt alertness management tools and strategies that you can use for yourself in your program. Ultimately, the goal of the talk in general is to try to just get it in your mind to think about sleepiness and fatigue during residency. A lot of this stuff is common sense, I understand, but hopefully it just kind of puts it in the forefront of your mind a little bit so that you're thinking about ways that you can help yourself to be more successful in residency. So I'm going to talk about what to do when you feel like this every day. All right, so some data on why we're talking about this topic in general. So this is a chart on that looked at how sleepy residents are. And so if you look on the y-axis is Epworth score, and I'll talk about this in a second. And on the x-axis is different populations. And so they looked at the Epworth score in normal individuals, insomnia patients, sleep apnea patients, residents, and narcolepsy patients. Okay, so let me explain to you first what the Epworth score is exactly. So we actually use this clinically in the sleep clinic. It's not just some made-up thing for a residency study. But the Epworth sleepiness score is a score that we use, that we give patients to rate how likely they are to fall asleep during certain activities. And so based on what their score is, we'll decide whether or not they're high risk for having a sleeping disorder. Okay? So if you go back to this chart, if you look at residents, their average Epworth score was 14. We consider 10 high risk for a sleep disorder. And then you see residents fall somewhere in between patients with sleep apnea and patients with narcolepsy. So it's clearly a problem in terms of the level of sleepiness in residents. Okay, so why is the problem of sleepiness and fatigue in residency underestimated? So it's multifactorial, but a big, huge thing is cultural norms, which is basically the culture of medicine. Now, things are a lot better than they were back in the days of when, House of God was written, where it was thought that, the more you worked, the better your training was going to be and a better doctor you were. So sleep is, in the culture of medicine, sleep is considered optional. And you're considered a wimp if you say you need it or if you're feeling tired, etc. And it's thought that less sleep equals a more dedicated doctor. So the perception in medicine is that if you reduce work hours, you're compromising patient care and you're reducing the educational opportunities you might have to see more patients, do more admissions, do more surgeries, etc. So we're going to talk a little bit about what causes sleepiness, a little bit of the pathophysiology behind it, and then we'll talk about ways of dealing with it. So physiologic factors that cause sleepiness. So a common myth, so it's the really boring noon conferences that put me to sleep. So environmental factors can certainly exacerbate previous sleepiness problems, but it's thought that those types of environmental factors can't actually cause sleepiness unless you have something underlying already, okay? So it's not just the boring noon conferences. All right, so we'll talk about daytime sleepiness in sort of a conceptual framework. Now, we actually kind of use this framework in sleep medicine as well when we're thinking about a differential diagnosis for daytime sleepiness. But in this slide, they kind of put it in terms of residency perspective. So excessive daytime sleepiness can be caused by a number of things. One can be circadian rhythm disruption, and we'll go through all of these sort of in more detail. And so that includes, rotating shifts like some of our ER residents do, night float rotations. And so if you're messing up your circadian rhythm, you may have some excessive daytime sleepiness or just sleepiness in general. Insufficient sleep can cause excessive daytime sleepiness. And that's, when you're on call, you're not sleeping enough. Or if you're not sleeping enough when you're not on call. Okay, so that's insufficient sleep. Fragmented sleep can cause excessive daytime sleepiness. So the dreaded tiger texts in the middle of the night or pagers, phone calls, etc., can cause excessive daytime sleepiness. And then primary sleep disorders like sleep apnea. So actually, when I was in fellowship, someone had done a grand rounds on this where they actually had a patient who was a physician who had gone through medical school, residency, very sleepy throughout the day. And he'd gone to like sleep doctors, and they'd told, it was always chalked up to, well, they're in training, and of course they're going to be tired. They're in med school, they're in residency, and went up to being an attending and was still having a lot of problems, and eventually was diagnosed with narcolepsy. Okay, so I think that obviously all of these factors are going to contribute to daytime sleepiness, but just kind of keeping in mind that residents can, and trainees in general, can have sleep apnea, narcolepsy, actually organic medical problems causing sleepiness, and just to be vigilant of that. Okay, another myth. So like a lot of residents, I only need 5 hours of sleep. So none of this applies to us. Okay, so the amount of sleep that you need is a genetically predetermined thing. So there are people who can get 4 to 5 hours of sleep and be totally fine. But for the most part, that's not the case for most people. So sleep loss is cumulative. So as the more and more nights you have with less than what you need of sleep, you're going to create a sleep debt, which eventually you have to make up. Okay, so the effects of sleep loss start to become evident when people start having less than 6 hours of sleep per night. That's an average number. For each person, that's going to be different depending on just genetic predisposition. Okay. So reducing the impact of sleep loss. So avoid starting out with a sleep deficit. So they did a study where they looked at, residents were reporting how much sleep they were getting on different rotations, and they found that even on light rotations or no call rotations, residents were getting an average of 6.3 hours of sleep. So I know it's so tempting, when you're a resident, you're working so much that when you're off, you want to do fun things, you want to spend time with your family, stuff like that. But I think it's important just to remember that, to take advantage of the time when you don't have to be in the hospital to make sure you're catching up on your sleep. Okay, another myth about adaptation to sleep loss. So I've learned not to need as much sleep during my residency. So like I just mentioned, so sleep is a genetically determined thing, and you can't change it, how much sleep that you need. And you can't train yourself to need less sleep. So you can train yourself to try to improve some of the performance of your tasks with effort, but your optimal performance and consistency of performance is never going to be there if you have a sleep deficit. So they actually did studies, if you look, where they took post-call residents and they compared their training years and actually did neurocognitive testing on them. And they found no difference in their performance on their neurocognitive testing from interns to PGY 3 or higher in terms of their neurocognitive testing. So having more experience with sleep loss is not going to make you better at functioning without sleep. Okay, so this is a polysomnogram. And so this, if you look on the x-axis is the hour of sleep that they're recording. And then on the y-axis, you'll see the stage of sleep. So just to give you guys context, REM sleep and stage 3 and 4 sleep, which are deep sleep, are considered the restorative stages of sleep. So the more of those stages you get, the better rested you feel in the morning. So these are actually, if you look at the top chart and the bottom chart, it's actually a comparison of young adults and elderly, but the Sleep Academy actually makes a comparison to this could be more like normal sleep versus on-call sleep. And so if you look at the chart at the top, this is a normal sleep polysomnogram. And if you look at this dark black line, this is how much REM sleep you get during the night. And as you progress later on in the night, you have more and more REM sleep. And then you'll see how much like stage 3 and 4 sleep they get also as in the normal chart. Now, if you looked at the chart where with on-call sleep, where whoever this person is that they think they're recording is getting interrupted a lot in their sleep, you'll see that the amount of REM sleep here is significantly less. And you see they barely hit any stage 3 or 4 sleep. Okay, so you can imagine that that does not feel like restorative sleep. So that's sort of the comparison that they're making. But again, these are the charts of the young adults and elderly. It's not an actual polysomnogram of a resident. Okay, so how the circadian clock impacts you. So it is a lot easier to stay up later than to try to fall asleep earlier. So it's easier then when you have shift work to adapt to shifts in a forward fashion. So going from like a day shift to like a swing shift and a night shift. So a lot of ER residencies actually are trying to move towards making their schedules a little bit more like this, where they're not just like flipping randomly between day and night or a swing shift. They're actually moving forward in their shift change. So based on this. Okay, so physiologic determinants of sleepiness. So this is a normal sort of chart of the components that cause someone to be sleepy. So you have a sleep drive. That's the top arrows right here in green. And this increases throughout the day as you're working. And then your circadian drive. And your circadian drive for wakefulness kind of keeps going up during the day and then falls in the nighttime. And then you'll see that there's a dip in your circadian drive around 3 p.m. And then, you know, the lowest during the night is 3 a.m. And so that'll come up later in the presentation on how you can take advantage of that. But you'll notice if you do night shifts and things like that, the first few nights, like that's when you feel the worst, right? When you're on your night flow is like between the hours of 3 and 6 a.m. So that's because of your circadian drive. So between the sleep drive and the circadian drive for wakefulness, that's what's going to determine how awake you feel. Okay, so what are the consequences of sleep deprivation? So again, a lot of this is common sense. Most of the goals of this is to just make sure you guys are thinking about it on a regular basis. So a sleep-deprived resident can have an impact on a lot of things, both in the workplace and at home. So a couple big things: driving safety, patient care and professionalism, your learning, health and well-being, family relationships, mood and performance, and the workplace in general. And so we'll talk about all of these things and sort of the data behind it. Impact on professionalism. So this is a quote taken from a focus group on sleep deprivation. And someone quoted that, you know, your own patients have become the enemy because they're the one thing that stands between you and a few hours of sleep. And I know that everyone's kind of had this scenario where they're like, night shift is just ending and they have a patient that they're just admitting and they're talking forever and you're past your shift and, you know, you feel like, you know, oh my gosh, it's the one thing that's keeping me from going home and going to sleep. So it's not an uncommon feeling. And the problem becomes, though, is that if it becomes a regular feeling. Okay, so a little bit of data actually surrounding what residents are more likely to report when they have less than 5 hours of sleep a night. Okay, so this was a lot of these studies are self-reported studies by residents, so they report these events that happen. So for residents that average less than 5 hours of sleep, they're more likely to report involvement in a malpractice suit, the use of medications to stay awake, serious conflicts with other residents, accidents and injuries, serious medical error, weight changes, alcohol use, and then conflict with nursing staff. So you can see that these make up things that are serious things in your workplace and serious things in your personal life as well. And see the odds ratios on all of these are greater than 1. Okay, so how does your average number of hours of sleep impact your residency experience? So this is, again, another self-reported study for the residents. And basically what they charted was on the x-axis, the average reported daily sleep, and then on the y-axis is, how likely they felt this certain scenario. So for instance, on the yellow line, if you look at the less than 4 hours of sleep category, residents were more likely to report higher levels of stress. And then if you follow this yellow line down to the 8 hours of sleep, the stress reporting goes down. If you look at the level of learning, you'll see that, or quality of learning, you'll see that it's reported as less in the less than 4 hours of sleep category, and then that increases as you increase the amount of sleep. And then the feelings of belittlement and humiliation, they interestingly are higher with less than 4 hours of sleep a night. And then as you move on to the 7 to 8 hours of sleep a night, you have less feelings of belittlement and humiliation reported in residents who have more sleep. Okay. And then the impact of performance and fatigue. So this is a meta-analysis that they did of 20 studies involving residents to see what the specific factors that were involved with sleep deprivation. And they found that 24 hours of sleep deprivation was associated with a significant decline in vigilance, memory, cognitive performance, and clinical performance. And I'll show you some specific data related to all of those items. Okay, so this is another resident self-reported study. And residents reported kind of the average number of hours of sleep that they were getting and the amount of errors that they were reporting. So they did errors and they did adverse events. So if you look at the yellow bars, this is the total number of errors, and the green bars are adverse events. In the less than 4 hours of sleep category, you'll see that there are much higher numbers of the percentage of errors and adverse events. And when you go down to the 7 to 8 hours of sleep category, there's less errors reported and less adverse events reported. Yes?
You may have said this in the introduction, but I'm sorry I missed that. You got a lot of data here. Are they treating residents and all it as all the same, or did they look at different levels of training?
No, they used all the residents in general, not different levels of. In specific studies, I'll talk, if they did separate them, I'd mention that, but otherwise in these, they kind of bunched them all up together. A resident is a resident, intern or resident, whatever, yeah. Okay, this is a really old study. It's from 1971, but it's sort of telling of sort of the attention tasks and what kind of what starts to deteriorate when you have less sleep. So basically they looked at medical interns, so this was interns specifically, and they compared interns who were well rested, which was an average of 7 hours of sleep, compared to interns who were sleep deprived or post-call, which was 1.8 hours of sleep, which is really low. But anyway, so they had them do an ECG sustained attention task, which was basically, watch the telemetry and see if pick up all the arrhythmias. And they found that there was a significantly more errors on that attention task in the interns who were sleep deprived. Okay, and then I have some residency-specific data as well. So for surgery, there were 20% more errors and 14% more time required to perform a simulated laparoscopic surgery post-call. And then there was a pediatric study that showed that the time required to place an arterial line was significantly increased in a sleep-deprived resident. For emergency medicine, there was a study done that showed significant reduction in the comprehensiveness of a history and physical documented by second-year residents specifically. And then in family medicine, there was a study that showed that the scores on their in-training exams were correlated with the amount of sleep that they were getting at night. So there's multiple effects both on the clinical side, test-taking abilities, cognitive side in terms of reduced sleep. Okay, so this is another attention study, and this was interns specifically. And this one actually measured EEG readings and their attentional failures depending on how much sleep they got. So in this study, in the green group is interns who had a traditional Q3 24 to 30 hour shift. And then in the yellow bar is interns who had shifts that were less than 16 hours, like kind of how we have our work hour restrictions now. So you'll see that on EEG, there's a greater number of attentional failures in interns who had the longer shifts compared to the interns who had the 16-hour work restriction. Okay, and then this study, this was also an intern study where they looked at how much diagnostic errors, medical errors in general, that interns had depending on their type of schedule. So again, in the yellow, you have the 30-hour shifts, and in the green, you have the 16-hour kind of capped shifts. And you'll see that there's a significantly increased number of errors reported, serious medical errors in the longer shifts in the yellow bars, and including serious diagnostic errors and serious medication errors. Okay, so now we'll talk about drowsy driving, which is an important, very important topic. Okay, so there are potential legal implications for house staff and hospitals when driving drowsy. In New Jersey, as an example, it's considered if you're driving after having not having sleep for more than 24 hours, it's considered reckless explicitly. I didn't research it myself about the Tennessee laws specifically, but there's been a lot of high-profile cases in courts that have accused actually hospitals of being responsible for fatigue-related crashes of their staff after they've left. Okay, so that's legal implications, but we also want to talk about, in terms of personal implications, we want you guys to be safe when you're driving home after a shift. So how do you recognize signs of driving while drowsy? So if there's trouble focusing on the road, again, some of this is common sense, but I just want it to be in your heads and kind of active, something that you're actively thinking about while you're in training. So trouble focusing on the road, difficulty keeping your eyes open, nodding off, yawning, drifting from your lane, missing stop signs, stoplights, not remembering that you drove the last few miles, or not remembering that you drove home, and then closing your eyes or nodding off during the stoplights. Okay, so what works? The best thing is to avoid driving if drowsy. So what can you do if you want to get home and you're really sleepy? So we're in the age of rideshare, so Uber or Lyft is something you should take advantage of. Get a ride home, public transportation. You can take a nap in your call room after your shift and before going home, or drinking some caffeine. If you do start driving and you notice signs of sleepiness, pull off to the side of the road and take a nap. Okay. And then things that don't work. So turning up the radio, opening the car window, chewing gum, things like that are not going to keep you awake. Okay, so the best thing is to just not drive while you're sleepy. Okay, so what does fatigue and daytime sleepiness, how does that impact your medical education? So this is a quote again from a focus group on resident fatigue and sleepiness, and that was pulled out. So we all know that you stop learning after 12 or 13 or 14 hours. You don't learn anything except how to cut corners and how to survive, well, regardless of whether you agree with that or not. So there is some data on learning satisfaction and correlating it with sleep time. So, and this is so if you look at the x-axis again, this is the average reported daily sleep, and then on the y-axis you'll see resident ratings. And if you look, let's see, if we look at the perception of learning quality, so that's in the red line. If you look at the less than 4 hours of sleep category, it's lower. And then as you go up higher, your ratings increase. Interestingly, your quality of time and the perceived contact with the attending, if you look, it's much less in the less than 4 hours of sleep category, and then that increases as you get more sleep. So like objectively, it's probably not different for those residents, but subjectively, they feel like they have less contact with the attending. So I think that's a little interesting. Okay. Recognizing sleepiness in yourself and others. Okay. Estimating sleepiness. So here's a big myth for some people. I can tell how tired I am, and I know when I'm not functioning up to par. And this is part of the reason we're doing this presentation, is to make sure that you are critical about the statement. So after almost 50% of the time, they're actually asleep. Anesthesia residents did not perceive themselves to be asleep. And this was a study that they did. I think it was an EEG-based study, so where they actually saw that the anesthesia residents had, based on EEG, fallen asleep, but they didn't recognize it 50% of the time. The sleepier you are, the less accurate your perception of your degree of impairment. So it's kind of similar to alcohol and inebriation. So the drunker you are, you might not perceive how drunk you are, right? So it's the same thing for sleepiness. And you can fall asleep briefly without knowing it, and that's called microsleeps, where you can recognize it sort of on EEG and actually have an attentional failure, but maybe not realize that you missed a couple of seconds or a couple minutes of your life because of a microsleep. Okay, the impact of continued wakefulness. So another myth, right? So if I can just get through the night, I'm fine in the morning. So performance does decline rapidly after 15 to 16 hours of continued wakefulness. And your lowest alertness after being up all night is between 6 a.m. and 11 a.m. Okay, so that's like morning rounds, basically. So what kinds of warning signs can you try to recognize that you're falling asleep or that you're sleepy? Again, common sense. So if you're falling asleep in your conferences or on rounds, then you're sleepy. Feeling restless and irritable with people that you shouldn't be or normally are not. Having to check your work repeatedly, having difficulty focusing on the care of your patients, and feeling like you just don't care. These are all similar to burnout feelings as well. Okay, so what kinds of strategies can you have? Because you can't help it sometimes, right? You have to round in the morning. So how can you manage that alertness? So napping strategies. So one myth is that I'd rather just power through when I'm tired, and even when I nap, it just makes me feel worse. So some sleep is always better than no sleep, but you kind of have to be strategic about how long you nap and at what time you nap. The pros of napping is that it temporarily improves your alertness. You can do preventative napping, so that's pre-call, versus operational, which is on the job. Okay, so when you're on night float or you're just starting and you have a slow couple of hours, you can nap. So short naps should be no longer than 30 minutes to avoid sleep inertia. So sleep inertia is usually occurs in the deeper stages of sleep. So REM sleep, stage 3 and 4 sleep are going to be where you have sleep inertia. So you'll notice if you get, like, even when you're sleeping at home, if you get suddenly woken up during that type of sleep, you're going to feel excessively more sleepy than if you were to wake up naturally and come out of your stages of sleep. And so that's when you have sleep inertia, where the feelings of sleep from your deep sleep are continuing on. So you're going to fall into those deep stages of sleep more. You're more likely to fall into deep stages of sleep after 30 minutes of napping, which is why you should avoid kind of going that long. Now, if you're already sleep deprived, sleep deprived people get into deep sleep and REM sleep much faster than people who are not sleep deprived. So that's the one caveat of the 30-minute nap time, is that you might get into your REM sleep within 5 minutes. And so you might still feel that sleep inertia. And basically when you wake up from a nap and feel like awful, that's sleep inertia. So the other thing about napping is to take advantage of circadian windows of opportunity. So like I showed you that chart on your circadian rhythm. So your lowest levels of wakefulness based on your circadian rhythm are going to be around 3 p.m. and 3 a.m. Okay, so that's probably the best time for you to nap and get the most bang for your buck in terms of being awake. Okay. Recovery from sleep loss. So another myth. So all I need is my usual 5 to 6 hours the night after call and I'm fine. So it does take at least 2 nights of more than usual sleep to restore baseline alertness. So I used to do this as a resident. Don't do this, but I would feel so bad about not being home to do things because I was so busy in residency that after post-call, I would just stay up and stay up the whole day the next day to run errands, to do something fun, and then sleep that night. The next day, you feel terrible, right? Because you haven't caught up on any of that sleep. And so that's something I would not recommend you guys do. But it does take some catching up. And it's going to take a few days. So it's something to keep in mind when you're post-call. If it's one night of call, it'll probably take about 2 nights. But if it's going to be like a week of sleep deprivation, it may take more than 2 days. Do I know the exact number? It's probably different for everybody. Yeah. Okay, caffeine. So I know you guys are probably better experts at this than I am, but it does reduce some sleep-related deficits. Strategic consumption is key. So it takes about 15 to 30 minutes after you drink it to work. Okay, your half-life is going to be 3 to 7 hours. And the only issues is that you can develop tolerance. It's going to make you pee a lot, and it can disrupt subsequent sleep. Okay, so just be careful about, if you know you're going home soon, like in the morning, post-call, just try not to drink it so that you can get some of your post-call sleep as well. Okay, healthy sleep habits. So this is something that can also translate to your patients if you're trying to help treat your patients in a non-medication way for insomnia. But for yourselves as well, to try to keep healthy sleep habits. So just realize that your circadian rhythms and your sleep needs are non-negotiable. So as much as you would like to be that person who can only sleep 4 to 5 hours and do a whole bunch of things and still be fine, I think just realizing that you're not that person is really important. To go to bed and get up around the same time every day, that's difficult in residency. I know that because your schedules are always going to be different. But one thing is that, especially if you're somebody who also has insomnia issues, it helps to do that. And on the weekends, kind of sticking to whatever your schedule is or on your days off, a little bit towards what you do during the week does help with some of that pattern. And what I would say is if you're trying to catch up on sleep, instead of sleeping in a lot, maybe just taking a nap as a way of catching up on your sleep rather than kind of messing up your schedule from the week. Develop a pre-sleep routine. So using some sort of relaxation methods and doing a standard thing every time when you're going to sleep. Some people listen to music, read a book, take a hot shower, whatever it is, but have it be the same thing and have it every night. And then protecting your sleep time. So this is so hard in the era of tiger text. I don't know about you guys, but when I'm at home, I get tiger texted still all the time. And so I think, there is a do not disturb function on there. I would say use it when you're not in the hospital and to try to help protect your sleep. And also when you're on night float or working nights or call, tell your friends and family that I'm on night float this week, So, maybe for the unnecessary phone calls and texts and stuff during the day, try to keep it to a minimum so that you can get your sleep during the day. And then if you know you're going to be on call, don't go out partying the night before. So, which I've done before too. So you try to get more sleep the night before a call. Okay. And again, this is all applicable to your patients too. If you have patients who have insomnia issues, this is great advice for them before you start giving them Ambien. Okay. Other healthy sleep habit recommendations. So your sleeping environment, you want it to be dark and cool. So light blocking blinds or curtains are really important where you're sleeping, especially if you do a lot of night shifts. It helps to sleep during the day if you have something that darkens your room. Keeping it quiet, obviously. And then another thing that helps is not having any TV, iPad, or cell phone in the bed. So a lot of my patients will say I can't sleep, but they play with their iPad in bed or on their phone in bed. And there has been data that the light from those devices gives you more propensity to stay awake. And so kind of trying to limit that in the bedroom and in bed is really important because it helps just create the sense that, when you're in your bed, that's sleep time. So that's really important. Avoid going to bed hungry, but no heavy meals within 3 hours of sleep. So that's because of increased risk of GERD, and GERD being contributing to you staying awake. So that's what that recommendation comes from. Getting regular exercise, again, it's very hard to do that as a resident, but and to not do it within 3 hours of going to sleep. So I know that's pretty much all you have during the day when you get home, but it's something to keep in mind. And then using alcohol to fall asleep. So it works to help you fall asleep, alcohol, but it has been shown to be disruptive. So it'll cause you to be less likely to be in deep stages of sleep, and you'll be in and out of stage 1 and 2 sleep a lot more when you've had alcohol to help you fall asleep. So that's something to keep in mind, is that your quality of sleep is never going to be as good if you use alcohol. Okay, so some recommendations for night float. So actually some of our night nurse practitioners use this stuff a lot. So I told you protect your sleep and to try to nap before work. But consider splitting your sleep during the day into 2 4-hour periods. So I don't know if some of you guys have this problem, but if I work a night and then sleep in the morning, I get hungry around lunchtime and it wakes me up. So one strategy is to just go ahead and plan on waking up around noon and having a light snack, and then sleeping another 4 hours or so. And so that way you can kind of break up your sleep, but still get a total amount of proper amount of sleep. Try to have as much light exposure when you need to be alert. And then when you're going home to go sleep, to wear dark sunglasses. Try to prevent as much light exposure as possible. Yeah, go ahead. For your visor? That's a good question. I don't know, actually. I just know that we recommend just don't use the phone in the bedroom and stuff like that. But in terms of filters, I don't know. I don't know the data on it. Okay. All right, so operational measures to reduce fatigue. So I'm almost done, okay? So you guys would survive this. So Dr. Punda is here, so she can tell you more about our wellness strategies here. But just in general, in terms of institution-wide, measures to try to prevent fatigue. So supporting resident well-being. So monitoring depression and burnout rates are really important to figure out and make sure that we're doing the right things to help treat this sort of problem. So resident depression has been associated with chronic sleep deprivation, and up to 3/4 of residents report burnout symptoms, and it has had positive associations with workload and work hours. And this has led to resident duty hour restrictions. And so whether or not you sort of agree with the resident duty hour restrictions, I will just give you a little bit of data on the trials that have been done on this, because there was a lot of controversy when the first 16-hour limitation of work hours came about, because it was done based on very little data. And so they were seeking out a little bit more data on why we did this, whether it's actually important or not. So this was a surgical trial. It was the first trial, which was a non-inferiority trial on a strict schedule versus flexible schedule. So strict means that they followed the duty hour 16-hour restriction, and flexible schedule was based on an older model, which means that they were allowed to have their 30-hour calls and there were no restrictions on all that stuff. And they basically looked at patient care quality, resident satisfaction, and the quality of education. They found no difference in that between those two schedules. And then the iCompare trial, which came out a little bit after, which did internal medicine programs and did sort of a similar thing where they looked at strict schedules versus flexible schedules. So restricted hours in the strict schedule and flexible hours, so longer work hours, et cetera. They found that the burnout rates were similar, but there was less resident satisfaction in the flexible schedule. So there are so many problems with studies like this. There's so many confounding factors. But I think it's a step in the right direction in trying to figure out what the right answer is in terms of, are longer hours better for learning, or is it just increase the length of your day but not really increase your educational quality of life? Okay, so in summary, fatigue is an impairment like alcohol or drugs. So that's why don't drive while you're sleeping. Drowsiness, sleepiness, and fatigue cannot be eliminated in residency. You know, life is how it is, and we try our best to work on things like resident well-being and work hour restrictions and things like that. But until we figure that out, we want you guys to be able to have the tools to manage it. So recognition of sleepiness and fatigue and using alertness management strategies are ways that you can combat sleepiness in residency. And if you're having a lot of trouble with this, to talk to some of your supervisors and your program directors about that. So, and I know in our program we're all willing to talk to you about it, and I'm sure in all of your other programs as well. Does anyone have any questions? Okay, guys, thanks for listening.
This conference is no longer being recorded.